As you guys know, all of that stuff from like weeks ago that you dumped, no, you haven't dumped it, right? It's still there. We only overlap a little bit. Before I talk about block 2 though, you guys did really well on block 1. It's hard. You knew the material, you just like maybe just the iPad test spring. You guys did really well, and I like math, except for statistics. I'm not like a statistics person, but the people who are statistics people here at iPad said you guys did well. Like just you killed it. So good job. So the second block, usually you guys classes do better, and you guys already did really, really well in the first test. So keep it up. But the reason I think you do better, the concepts are a little more straightforward. Like obesity, it's really hard to get too far in the weeds in a question, right? It's a straightforward concept. And then diabetes is not something new, right? You guys have been learning about diabetes. You taught diabetes medication. So when we get into that, it'll be kind of a review and maybe building on knowledge that you already have. And that's going to be the biggest topic. So most of my questions are going to come from diabetes because I have a part 1 and a part 2 and a lab. And then all of these 3 all have to do with androgens and androgen mismatches. And I think they're really fun topics. And they build on each other, so that's a plus. And then at the end you have calcium metabolism, which I still have to post the slides because I always, every semester I try to like simplify it or clean it up. And it's just, I don't know. I'll get to it. I will post it soon. But that's what we have ahead of us. So obesity, technically on the pants it falls under GI, but it makes sense. It works with us, especially before we talk about diabetes. So lots of things we're going to go over. But first, let's talk about this. What do you guys see? Yeah, where is it? That adipose tissue. It's like on, obviously the fat pad, but just might not necessarily be Cushing. But look at the organs. Where do you think the scariest, like high-risk adipose tissue buildup is? What part of the body? Heart, yeah, heart is not good. But we can't see that. I won't. What about externally? When is it scary? If I see where if I had excess weight, where would it be scary? Abdomen. Yeah. Abdomen is associated with risk, especially risk. If someone has adipose tissue on the central obesity in their abdomen and hips, then guarantee they probably have excess adipose tissue on their organs, which is a problem. Has anybody seen fat on a heart or like internal organs? It's crazy. I was the last time I was in the OR was for a trauma course called C-STARS, right before I came to IPAT, and we were doing a bypass surgery week. I was with the anesthesiologist, so I was just intubating. But this man had a lot of adipose tissue on his heart, and then the anesthesiologist was talking about having McDonald's for breakfast. So I don't know. Okay, so this is, the next few slides are kind of like, it's interactive, shake off the lunch lull and GI post-test doc and participate a little bit. So here is a site of the United States, and it's data from the National Health and Nutrition Examination Survey. So it's a survey done, it's a self-reported one partially, so again, it's not a perfect study. But it consists of interviews, and they would go to some of the participants' homes and do like maybe a mini physical exam, get some weight and height and, measurements and things like that. Okay, so this is, and it started in 2011. So let's look at what the colors mean. So green is good in relation to obesity. So if you have green, only 20 to 25% of the population are obese. And then the darker we get to red, over 35% is red. So what do you notice, just like geographically? Where's the red? Or I guess it's orange. Where's the orange? Yeah, in the south. Okay, let's see what happens a few years later. Now we have red. So over 35% of the population in these 3 states are obese. But we have a little bit less green too, right? That orange is spreading. 2 years later, more red, more orange, only a few green, right? Big surprise, 2018, the red is growing up there through the middle. Colorado and DC are holding out. And then next year, same, more obesity, right? I know. So let's pause here. So remember they had 35% was the cutoff. They actually changed in 2021, so post-COVID. They changed it and they added a 40 to 45%, 45 to 50%. So they added more criteria to just to the red, to the scale of the red. But again, where's the green? It's not, I guess DC. Yeah. But again, I think this is 2021, COVID, maybe we weren't as active. Other people were more active, I don't know. Okay, 2022, yeah. A lot of red, dark orange. Bird sienna, I don't know. 2023. Is this surprising?
No.
No. So if we had to guess, what do you think 2030, what percentage of adults in the US would be overweight or obese? 100%? No, a little less. 12%? No. What percent of the population in 2030 use obese and or overweight?
90.
90? Okay, yeah. So they anticipate 86. So it's probably not going to look like that, but yeah, the red blob, right? Like it's spreading. So what's the take home here is that obesity is significant and it's affecting all over the United States. So it doesn't matter if you're choosing activity or dependence or a mix or pediatrics. Obesity is something you're going to run into as kids. And the concept of it seems fairly straightforward, but you'll see from here, hopefully by the end, that we're not doing the best at treating it and preventing it. So again, the progression of obesity, after the age of 18, you typically gain a couple pounds a year. And so you can see over time how that contributes to the data. Here's some statistics. About 42% of US adults are obese or more. And look at the kids, almost 20%. I think it was 18 the previous year. So it's going in the wrong direction. And then obviously it costs money. But more important than money is just like the association with other comorbidities, right? Hypertension, cardiovascular disease, diabetes, all of these things. So it's a big deal, right? It's something we have to be comfortable talking about when we're in clinic. Because I'll tell you, a lot of times people come in and they don't come in for their weight. They come in for other things and you can't just ignore it, right? You have to be able to bring it up. This is just stuff I pulled not from Current, and again, just that they're anticipating the increase of obesity. Now, this was this year. GLP-1s have really changed a lot, so this may be different now. But I thought it was interesting that they're considering a new classification for obesity, so it's like preclinical and clinical obesity. Why do you think they would add preclinical? Yeah, just like prediabetes, we can tackle it before. So again, they're trying to break that and really maybe bring more attention to it. Because if someone comes in with 5 other things, I'm going to think about hypertension, quit smoking, your back pain, and we sometimes forget about the obesity, right? So maybe those new classifications will help. And there's a lot of like internists or family medicine docs will like specialize in obesity medicine. So there's obesity medicine clinics and things like that weren't there before. Okay, so one of the most common, also frustrating and difficult to manage for you and for your patients, right? If this was easy, losing weight was easy, then we wouldn't have that red blob, right? There's lots of considerations that go to that increase in obesity. And unfortunately, little progress has been made at preventing it or stopping it. What do you think are factors that make this hard? Cosmological? Or what are factors that make it hard for a patient to lose weight? Socioeconomic is huge, right? What else? Yes, convenience. Like I could just go to McDonald's. I have like when I get off the exit of my house, there's like In-N-Out, but I don't know. There's all these convenient foods, right? So that also like the overload. Think if you have I don't have TikTok, but like if you have those things, you have all these people telling you eat this, eat that, don't do this. So like information overload, right? So it can be hard to navigate that. Cultural influences, right? So different cultures eat different foods, and that plays a role. Education, money, lots of factors, right? So it's not just like, oh, they're lazy. So we're going to steer away from that. Hopefully you understand that already, but if you don't, I'm going to shine a light up that it's not necessarily just laziness. Okay. So, and then we need to do better at prevention. So body mass index, you guys are all familiar with that? Yeah? Okay. So we know that obesity has to do with visceral fat, right? Subcutaneous fat and visceral fat on the organs. We can't just go in and measure your visceral fat just in clinic, right? So we use BMI, and it looks at the height and weight. And it's easy to calculate. You can just go on your iPhone and you can do it, or a lot of times your EMR, your medical record system, will calculate it itself. Studies show that it correlates to risk. Is it perfect? What do you guys think? No, not at all. Because it doesn't show body composition. It doesn't show me what this patient looks like. It doesn't show me if their weight is around the belly. Or maybe they're like just a super big, fit guy, and the BMI is elevated, but they have like 12% body fat, right? So it doesn't reflect composition, especially for males or even elderly too. But again, it's convenient, and the data shows that it's somewhat helpful and it correlates to risk. So here's a table. I don't think anyone uses the table anymore, but here we go. So I would start this slide, because this is something that I can use to potentially understand obesity and how we classify it. So the World Health Organization uses this classification, and we will use this classification in clinic. So depending on if I can start somebody on obesity medication or even refer them for surgery, I use BMI and like their past medical history. So the best way to remember this is by 5. So if you remember overweight is at 25, and go up by 5. So obesity class 1 is 30, obesity class 2, 35, class 3 is 40. Okay? So we'll practice a bunch. So again, so if you remember 25 and go up by 5, you'll be able to tell me which class they are. Okay? And obviously, what are they at more risk the higher the class?
Yes.
Yeah, right? So again, easy concept. I'm sure you guys are with me. Another long day. All right, so again, this is easy to check. We like BMI because it's associated with health risks. There's data behind it. It's a quick, easy, vital. But again, it doesn't tell me if this excess weight is muscle or if it's fat or the location. So these are all things we've already talked about, pros and cons of it. So in addition to BMI, what else could we use to help assess obesity? What's another like test we can do with a measuring tape?
Height, waist?
Yeah, height and waist. Specifically, you could do a ratio, or you can just do a waist measurement. Do you guys remember in cardiology when they cared about, when do we care about waist circumference? Certain syndrome cards.
Heart failure?
It used to be called syndrome X. We don't call it that anymore. This metabolic syndrome. Okay, metabolic syndrome. We'll talk about it too. Don't worry. But so waist circumference is a piece of that. So in addition to BMI, we can measure their waist. So we know that for men, if their waist circumference is over 40, they're at risk, and 35 for women. And women typically hold their weight, not all, but hold a little bit more weight in their thighs, where men typically don't gain it. You can do the height to the waist hip ratio as well. For Endo, for this test, it's the BMI classification, and then the waist circumference helps with metabolic syndrome. So we're kind of we're overlapping between this lecture and diabetes lecture. So these are two. And then there should be no surprise that with a high increase in waist circumference and a high increase in BMI, you have an increased risk for other things. They go together, right? As BMI goes up, typically, not always, waist circumference goes up too. And there's no overlap. Okay. So again, for males over 40 inches, females over 35. This is more just FYI, just built differently, and you can use different, this kind of explains the waist to hip ratio if you want to use that in clinic. When I was at a diabetes conference, they talked about measuring people's waist, and they also talked about pedometer, how many steps you took, and how many steps you took a day can be a risk factor with cardiovascular disease and diabetes. So maybe one day that'll be another vital sign. Okay, so location is key. We talked about the abdomen and flank, right? That's the most concerning and significant risk for cardiovascular disease, okay? Is that visceral fat that is hazardous and scary, the fat around the organs we're worried about, okay? And then because it's associated with insulin resistance, and then metabolic complications and obviously diabetes. Is this all in like review? Am I going too fast? I'm intentionally going to try to go fast because I'm teaching back to back today. So maybe we won't have to stay till 5, but I'll be here. I don't know if you guys will be awake till 5. But tell me to slow down if I need to, okay? All right, just to hit home, visceral fat, right? Where is it? Where is it? Okay, so we talk about obesity. You hear me say obesity all the time, but how do we talk to a patient about this? How are you going to bring this up to a patient? It can be a little uncomfortable, just like you guys learned in med history in freshman semester and in ClinCore that we talk to maybe like an elderly patient differently than a teenager, right? When we ask them about do you use illicit drugs or their sexual history, we might bring that up a little bit differently with different patients, right? So if I just say someone's like you're morbidly obese, do you think that patient might be open to hearing what I say? Yeah. No, right? And so if you want, there's some terminology. This is from the Obesity Medicine Association. This is more for clinic, but they discovered that when you use terms like fat, which makes sense, morbid obese, that people are like either receptive or it just doesn't work again. I think if you use heaviness or large size, to me that doesn't hit home that this is actually, that this seems like kind of generic and don't like have like as much medicine to it, like a true diagnosis to it, to me. But encouraged terms are using unhealthy weight, overweight. But again, if they're obese, you should say something more than overweight. You can use the BMI. I have never said excessive energy stores in my life. But hey, I guess it's the two. I don't know how, again, you tweak it how you want, but again, just if you don't address it or bring it up, it's just how you do it, right? So that you can build that relationship with your patient. And later on, I'll have a graph that kind of shows how people do when they have, basically they do better when they have a good relationship with their PCM, okay? So we're not going to ignore it. We're going to be mindful of our language. We're going to remember we have like a busy day and patients are coming in with multiple issues, but remember that the weight gain is associated with so many other things in health, right? So we can't just ignore it. So this kind of highlights that. I like this table from Current. It's kind of cool. So like, there's no animations, right? Okay. So you have excess fat storage in the center, and that's obesity. And then I think the long arrows, the long arrows stress consequences, and then the short are a parameter. Okay, cool. But anyway, so if you have excess visceral storage, look at it messes with your hormones, right? Thyroid hormones, sympathetic hormone, metabolic rate, then that affects your heart. All the things that plays with your kidneys and your heart when you have hypertension, coronary artery disease. Excess estrogen, which we'll talk about this aromatase process with a mismatch of estrogen, and you can get, it's associated with like gallstones and things like that. And then of course diabetes, right? Insulin resistance. You know, excess visceral fat increases the chances of insulin resistance. So again, it's a big deal. So this should be pretty common sense too, right? It's not, there's a huge genetic factor, so family history plays a huge role in obesity risk, as well as what? Environment. What we eat, what we don't eat, what if we move, if we don't move, right? So food, physical activity, and genetics play a role. Some people don't kind of forget about the genetic piece, but we think 46 to 60% genetics plays a role. So it's not like if your dad's big, it doesn't mean you're going to be big, you should just quit. Just eat whatever you want. No, don't do that because of this, right? You don't want to do that. But again, environment plays a role, but genetics too. Okay. High calorie intake for sure. This is what we're eating or not eating, and we're not moving. Behavioral factors are a really important thing to add, right? So it's like, what do I do at work? Am I sitting? Do I use food as a reward? So, yay, I got an A on my GI test today. I'm going to go out to eat. Yay, I made it to work on time. I'm going to go out to eat. I don't know. So you can find different ways that we reward a lot of times that. What about kids? What are kids usually doing nowadays that maybe they didn't before? Video games. Like I played video games a little bit, but not like it wasn't as accessible, right? They're on their phones all the time. They're not like stay outside till it's dark as much as they used to be, right? So more sedentary as well. And we sit as humans, as adults, we sit a lot more. You guys sit a lot right now, right? So you have to put an effort into. All right. Any questions on the background behind obesity? Stay with me. Pretty straightforward. All right, so we're going to talk about the workup. Obviously, a good history and physical exam features, and then labs, right? We'll kind of go with our same trend. So medical history is huge. Have they been struggling with weight for a really long time, or is it sudden? If it's sudden, and maybe I do a physical exam, maybe I'm thinking like a Cushing's or some kind of weird endocrine thing, right, or something else. But usually these people have struggled for a long time. It's how have they tried a lot of things to lose weight? Typically, by the time they come and bring it up to you, they've tried a lot of different diets and methods, and nothing is working. And they don't always try the safest things. Family history is important because there's a genetic component. Why is occupational important?
You sit.
Yeah, because sitting is so big. I forget what year it was, but they said that sitting at work is equivalent, some equivalents to tobacco use or something. I'm totally paraphrasing that, but it's not good, right? The more we sit, it's not the best. But I'm sure it's not just, it's like lots of factors. Tobacco, so a lot of times people who smoke they tend to be a little bit thinner, but there's not always. It's still be correlated with obesity, and then alcohol for sure. Why? We drink. What is alcohol? It's just empty calories. High sugary calories sometimes. And then if I drink to excess, am I probably going to snack attack and maybe eat a little less healthy, right? Yes, so good. Same in hand. Obviously asking them if they exercise. Oh, I got back on that twice, sorry. And then the psychosocial factors, so mood disorders, obviously like if they're struggling with their weight, they could have underlying depression before or related to the excess weight. Eating disorders, we think of anorexia, bulimia, but binge eating is a huge factor for people with obesity. And then, or just like overeating. And then abuse, if they have like some kind of trauma in their past, maybe they're coping with food instead of healthier ways. Okay? So making sure you get a good behavioral health history. And then sleep apnea, obviously excess weight, you have an increased risk of OSA. Physical exam, we know BMI. What BMI, what are overweight is what? 25. Class 1, 30. Class 2?
35.
Class 4?
Over 40.
Why are all of you that right? Okay, good. Blood pressure is important, right, because of hypertension. And then we want to look at the patient. So maybe I'll get a waist circumference. When am I concerned if I'm a male? If they're over
40.
what? 40 inches. Females, 35. Oh, look, another by 5s. Great. So again, just like assessing that visual appearance can tell us some things. But we need more than just a visual appearance, right? We need to maybe consider additional exam. We need to listen to their heart and lungs, but look for other things, especially stuff we've learned about, right? Hypothyroidism, let's check their thyroid gland. Was their weight gain rapid? Do they have purple striae and other things? And we might want to do some other workup. I'm going to be honest with you, the most of the time, if I'm working someone up for obesity, I check thyroid the vast majority of the time. I rarely check for Cushing's. That should make sense, right? Because Cushing's is so much less likely, and the most of the time they don't have it, and then the physical exams point to that, because they've usually been struggling with weight for a long time. Okay, questions so far? Feel good with we had a good history, spent a long time on history. Physical exam makes sense, we need to do one. And then, what labs do you think we should do? Thyroid, nurses, yeah. TSH, free T4, what else? If obesity is associated with cardiovascular disease, what should we check? Lipids, what else? Yeah, blood pressure. A1C for diabetes, right? And then like a CMP for liver, kidney disease. Fatty liver, is that GI, this test or previous test? Yeah, so fatty liver associated, we're gonna talk about that next block a little bit. And then, or in my lab, excuse me. And then kidney disease too. So, CMP is funny. So again, screening, I guess blood pressure shouldn't be there, sorry. Waist circumference, all of these labs. I'm not going to be like, what labs do you do for obesity workup, right? I just want you to know that it's like kind of like a wellness panel and understanding why am I ordering A1C? Why am I ordering CMP, right? It's those comorbidities. And then obviously, potentially a sleep study is in a lab is something we would do. Okay. So, conventional diet techniques. So, we're going to treatment. So, diet and exercise, which we'll go into different tools for that. But 20% of patients will lose 20 pounds and only maintain it for 2 years. So it's pretty good. 20 pounds is a lot, but maintenance is hard. So we identify that. And then only 5% will maintain a 40-pound loss. So the more weight they have to lose, the less likely they're going to keep it off. Okay. So again, so that's all no data you have to memorize. But that close relationship between their PA, doc, and P is important to adherence and being successful, and also helps with motivation. In addition to the partnership with you, maybe doing like a social group, workout group, Weight Watchers, whatever, those seem to help with motivation. Why do I say it says most diets do not cause significant sustained weight loss? Why? Yeah, it's either like unrealistic, you can't just you stop it, right? Because I can't just eat grapefruit all day, every day, or do a juice cleanse every day, all day, or what's the what is it, carnivore, or where you don't eat fruit, and I don't know, when they poop, they don't have fiber, or the keto, where the idea of like less sugar, I love that, but to maintain that all the time can be really hard, so adherence is hard with bad diets. And then they're just not sustainable, or maybe healthy, like eating grapefruits isn't a good idea. There's some really weird bad diets. I don't know if they're as big anymore. There were some weird ones out there, guys. Okay. So, but I will talk to you about, so we know there's lots of bad fad diets. I'll give you some tools of what you can recommend. All right, so why do we need to treat this, right? Why do we prioritize obesity? Think of that graph, right? Heart disease, diabetes, cardiovascular disease, already, hypertension, higher rates of depression, binge eating disorders. There's risk if I have an obese patient who has to go under surgery, or if they get pregnant, they can be at a higher risk, right? And then of course the social factors. Well, there's been much more of like a body positive movement in the last few years. Specifically women, I think, hit the brunt of the social factors more than men, but I could be wrong. But again, there's a stigma and all of that stuff. So again, why we need to attack this and treat this. So simplified approach, but effective, is diet plus exercise, okay? No treatment, no weight loss. So if you don't bring it up and you don't talk about it when they come in for their knee pain, we may not have that change. And then again, behavior modification is key, right? Not just, we need something sustainable. So let's go into this tool. This overlaps pretty much with current, but it's just like a little bit per year, so kept it. All right, so we utilize this to go into treatment. So first we're gonna look at nutrition and behavioral therapy. So unprocessed foods, right? We need to emphasize this, but you have to give your patients examples because they might not understand, because maybe socioeconomics, education, or they're just too damn busy to prioritize that or understand it. So give specific examples and tailor it to the patient if you can. So the Mediterranean diet, they don't pay me to say this, just the data points that the Mediterranean diet is the like #1 for diabetes, obesity maybe, and then maybe it's like 1 or 2 for hypertension. Depends on which association you look at, but Mediterranean diet, if you just have a short time and you want to give them something, give them tools to look that up and follow it. Low glycemic index, do you guys know what that is? It's like a tool to curb hunger, and it they classify foods related to blood sugar. So if you eat it's eating high refined sugary foods versus like fruits and vegetables and meats. So that's a tool sometimes you can use, which makes sense, right? But it's harder than you think it is because there's lots of those sugary things everywhere. Let's see, limit the high calorie, lack of nutrient foods, nutrient dense. And then guess what? Well, you guys are in the military, so you get to refer to a dietitian. So except for my Guard and Reserve, might not. So I remember I wasn't always able to do that. So at least when I was in school, a lot of the counseling came from me, or it will come from you, right? So, but we can use our dietitians. And I think the Army, you guys still have like your health. It was called like the Hawk in the Air Force, but like health performance stuff. I think that there might be like more dietitians and programs like that in the Army for sure than the Air Force. The Air Force cut it all, unfortunately. Okay, continue dietary strategies, again, pushing lifestyle and things like that. So the bottom block is what I say. So remember, I have like 15-20 minutes with the patient, and this is just my spiel. So I prefer us to eat real food, right? But not too much. Prioritize your protein and your vegetables and your fruit, right? So again, not KUX, it's your real foods. So where do you find that food? On the edge of the grocery store. So you kind of like make it practical and visual. Shop on the edge of the grocery store. But guess what? Food companies are sneaky and they want your money and they want you to buy more and more of their processed food. And so that sugary food is sneaking out to the edge of the grocery store. So if you're unsure, flip it over and look at the label. What do you think they should look at first on the label?
Added sugar?
Yeah, and there's lots. I don't know the right answer. Mine is added sugar, because like I look at sugar, and then if there's a lot of added sugar, maybe I put that back. Oh, well, it's like fat-free and all this stuff, and I look at the ingredients. If I don't know what half those ingredients are, or there's like 25 ingredients instead of 10, maybe that is like, maybe I should put that back, or that's like special treat. I say the grandma test is like, if your grandma wouldn't recognize it as food, maybe you should put it back. You guys are younger, so maybe your great grandma wouldn't recognize it as food. Maybe you should put it back or only eat it as on occasion. And then tracking the food, there's a lot of studies that say if you write it in a journal or use like MyFitnessPal or some other free app, and that helps because you actually write down what you're eating. Can be eye-opening for these people. They might not realize, like, say you're a mom or a dad and you think you're eating a certain amount, but what are you? You're snacking or you're grazing on your kids' foods. And sometimes those kids' foods taste good, but those goldfish aren't so great, right? And then exercise. So the preference I do with this is have them do what they like. If they don't like to run, then don't run. Do something else. Obviously, if you're in the military, you might not get to choose that. But if I tell you to go run and you're not a runner, you're not going to do it. So find something you enjoy. Skiing, dancing, hula hooping, I don't know, whatever it is, and set those goals, okay? But you have to bring it up. But that's my spiel. Obviously, you're probably not surprised I say it really fast, and then you can also create a little handout for them too. Behavior modifications, again, key to maintaining weight loss. You can give them all this education information, but if I don't clean out my pantry and I don't change and I don't like maybe do meal planning, or if I keep eating in front of the TV and mindlessly eat versus eat at the table and drink more water, then it's harder for it to stick. Does that make sense? So teaching about cues, and then obviously for people who are eating to cope, you need to use behavioral health. That's pretty straightforward. Social support is a big factor in sustaining this. Again, it's like whether you join like what is it? CrossFit CrossFit people, or jiu-jitsu, or Weight Watchers, or jazzercise. I don't know if that's a big new one, but those people usually do better because that social interaction and causes reinforcement or accountability. I've seen a thing for like a run club for you guys, stuff like that can kind of help. So get them into it. Maybe you recommend that. Any questions on diet and behavioral? Why it makes sense? All right, let's move. We need to move, right? So there's several advantages. You know this. There's just so many, either whether it's mental health, physical health, you gain muscle, lose excess weight. So exercise is really important. Aerobic exercise, I think they push aerobic quite a bit. In these studies, that high intensity workout is associated with greater amount of weight loss. But I probably really push like strength training, because I think more people need to lift weights than necessarily like run a lot. And I was a runner. But again, don't forget the importance of strength training and what that can do for people and burning fat, and then just changing body composition too. Okay, so this says moderate intensity for an hour per day. Don't memorize this stuff. Just understand you need to like get physical activity in. And when you're in clinic, there's resources you can use. You're not just making it up. You can use these resources like tennis or walking, things like that. And then weight resistance. I say more than 2 times a week, but that's what the recommendations are. Questions on moving? You guys know this already, right? Okay, now the meds. All right, we're going to slow down just to finish on this. So medications, how I determine if I can prescribe someone medicine is their BMI, okay? Now, before I talk about meds I want to prescribe, should I just make sure that I'm not causing the weight gain, right? Because medication side effects can cause weight, right? What are meds that cause weight gain? What is it? Yeah, or antidepressants, SSRIs. What else? Seizure meds can cause it. TCAs, you're using maybe like for migraine prevention. Yeah, there's lots of stuff we do. So we want to make sure we're not the ones causing it before we just throw another pill on it. And then obviously we want to really preface that you need to do all the behavioral changes, the lifestyle, the exercise, in addition to meds, okay? They just work way better when it's done together. So here are like meds to antipsychotics. Diabetic meds at the top are really important. We'll talk about that next, but like diabetes meds have came a long way. And when I was graduating, the main meds were here, and they both sulfonylureas, TZDs, cause weight gain. Now we have all these meds that cause weight loss or are weight neutral, which is pretty cool. Okay. All right, so part of a comprehensive weight loss program. So again, lifestyle is still important, right? We can't just stop that. BMI over 30, so class 1 obesity, or a BMI of 27 or higher with a weight-related comorbidity. So that's going to be your hypertension, your diabetes, cardiovascular disease, okay, kind of the metabolic stuff. I'm going to go through various meds, 5, but I don't preface the like mechanism of action. I might talk about it, but for the test, I want you to think of like which population, this is a good one for this patient versus not for this one, okay? I am on the side going to tell you which one TRICARE covers first, but that's not, that's just like more awareness, but it's not going to be how you would determine what med to use on the pants, right? So we're going to go with what makes best sense for the patient, okay? Not insurance coverage. But I add that because it's real life. Questions on that? So again, we want to monitor these patients really closely. If they're not losing weight on it, we're going to change to another one. We're gonna titrate slow, and we're gonna keep it on, we're not gonna be on it for too long if we don't have to. Okay, so our first medication is phentermine. Have you guys heard of that in pharm? Yeah. So increases uptake of norepinephrine, dopamine, and essentially it suppresses appetite. It works 4 to 6% of people it works well, 4 to 6% weight loss, but it's scheduled for medication, right? There's abuse potential. I can't just prescribe this without a DEA, okay? So I will tell you, for the first 10 years of my career, nobody prescribed this in the MTS. It's not until recently that we've been able to prescribe this build a prescription on base. In the past, I would have to have a DEA and I'd have to have them fill it off base. So this is a huge shift. You will, active duty, guys, you will potentially prescribe this or discuss this. It comes with pretty significant contraindications and adverse reactions, so dry mouth, restlessness, irritability. You can't give it to somebody who has anxiety, especially uncontrolled cardiac disease, and things like that, okay? Ideal for a young, healthy patient, okay? Because if I'm young and healthy, I probably don't have all the cardiovascular disease stuff going on. And TED weekly, FYI, it's first line for TRICARE, so you have to try this first when you get in the field. And it's also the most commonly prescribed anti-obesity med out that we have, at least for now. All right. We have, so phentermine on itself isn't ideal long term. So usually if it works, you have someone on it for like 6 months or so, and then you taper off. But what happens if you take away my phentermine? What do you think? My weight might go up. Now, not for everybody, and then I want it back, right? And so again, so they have this combination. This one, it combines phentermine with topiramate or Topamax, and the brand name is called Kysenia. This one you will probably see, and it combines the two medication, and it's you technically can use it a little bit longer. And again, but it's the same. I have the same phentermine side effects, right? So I don't want it to be an old patient with cardiovascular disease, anxiety, and things like that. I want a young, healthy patient who needs just a little help with like appetite suppression. Do you guys when do we use topiramate or Topamax? Do you remember? Just like seizures. And we use it for migraine prevention. That's when I prescribe it. The higher the dose, you're going to get tingling. Usually what I've seen, I don't know, maybe it's tingling everywhere, but I've had patients complain about tingling in their hands. And then they're dopey. So the higher the dose, they get like dopey, Topamax. So you can have some issues with that. And again, that's an option. Contrave, I've never prescribed this one. This is naltrexone and bupropion. So if you have somebody, bupropion, when do we use that?
For ADHD.
No, yeah, you can use it for mild ADHD, anxiety, right? So the side effect, it can be weight and usually cause weight loss. But combined with naltrexone, together you get almost a 6% weight loss. But it comes with side effects, nausea, vomiting, diarrhea, constipation, or GI side effects, headaches, sleep issues. You do not want to give this to a patient who has seizures, obviously someone with opioid use, psychotic disorders, things like that. You don't want to give this. Okay? But hey, if you have a patient who's young and healthy and also wants to quit smoking, maybe you can do this one. I have never prescribed this one myself, but these two, the first two. Now GLP-1s. Nobody, I think, alive doesn't know what GLP-1 is nowadays, but these work really, really well. I talk about the mechanism of action more in diabetes, but it's the gastrin inhibitory polypeptide, is a GLP-1. And the biggest thing with this is it kind of like decreases, like inhibits glucagon, it decreases the gastric emptying, so you're slowing the food process down so they get fuller faster, and it also helps with like the food noise and kind of that appetite trigger that people have. So it's been pretty effective. Obviously, you guys have heard it. Up to 20% of weight loss with semaglutide. I think I was going to say tirzepatide is probably even higher. I feel like it's probably even higher nowadays with 15 to 20%. But side effects, know this. What are the side effects? What do you think?
Diarrhea.
Diarrhea, vomiting, constipation makes sense, right? I'm slowing the GI tract down. Probably most common is like constipation, and then the nausea and vomiting. Typically, as you start low with the dose and you titrate up, they get used to the GI symptoms, okay? But this is one where the side effects match the kind of the mechanism of action, right? Ideal candidate is someone who needs help with like they overeat, or of course someone with diabetes or cardiovascular disease. It is considered a first-line medication, but typically TRICARE makes you try phentermine first. But if your patient's not a good candidate because they have hypertension or they didn't tolerate it, you just fill out a form and you can get it paid for. Okay. Questions on this? This guy's over the counter. Orlistat or Ali. It's a lipase inhibitor. You only get 3% of weight loss, and it causes like oily stools. Like, I'm not kidding, oily stools. I didn't know about this med, and a patient came in and was like, "Hey, what do you think of Ali?" And I was like, "What do I think of Ali? What is she talking about?" So I looked it up on Hippocrates, and I was like, "Ew." But yeah, oily Orlistat, oily stools. I wouldn't necessarily recommend it, but it's a tool in your tool belt where you could give a patient where they could potentially lose some weight, and yeah, but you need to warn them about like fecal incontinence. Like, that, but yeah, there you go. They could be taking it over the counter. This one I've been wanting to delete every semester, but I left it on. So the reason I left it on is there's like a obesity guideline from like 2018 that you could Google for MTFs, and this medication is on it. Velvic, it's not even a thing anymore, but just FYI, wouldn't recommend it. Overall, general considerations when we're going to treat somebody with medication for obesity. Uncontrolled cardiovascular disease, probably need to manage that first, right? We know that GLP-1s help with people who have heart disease, but we need to make sure that's controlled. Are we going to give phentermine to someone with uncontrolled? Yeah, no. Are we going to give someone pregnant or lactating diet meds? No, right? And then a history of psychotic disease, psychiatric disease, specifically like bipolar, schizophrenia, those bigger ones, we need to be cautious when we give these people. And all of these recommendations are for adults, not kids. You will treat I've either renewed prescriptions this summer when I was seeing patients, started them on it. Again, it's the same exact criteria. BMI over 30 or over 27 with obesity-related comorbidities. So, do you guys care? Do you want me to push through the surgery or pause? I'm going to give you a pause for sure. I'll push through. Yeah? Okay. All right. Bariatric surgery. Have you guys talked about this? Does GI talk about this? Probably not. Okay. So if you have a BMI of 40, which class is that? If I have a BMI of 40 or above, what class? 3. Yeah. Or 35, so class 2 with comorbidities. I can consider a referral to bariatric surgery. Okay? Typically, if they failed doing stuff on their own, they're really trying diet and exercise and it's not working. They've tried meds or they haven't tried meds. You don't have to fail medication to go to do weight loss surgery. It works. Obviously, if we're gonna review the surgeries real quick. It works. It's usually sustainable, but there have to be somebody who follows up. Improved quality of life is found out. Why does this make sense? So fewer than 1% of eligible, so those eligible, BMI of 40, over 40 or 35 with comorbidities, undergo surgery. That's because either insurance doesn't cover it, or maybe the PCM doesn't recommend it. That's like a big thing. The PCMs aren't referring it, or maybe the patient, obviously patient preference, that everybody wants to go over surgery. But this is a tool in your treatment management for obesity. Okay. No, it's bolded. Yeah. Know that. Okay. So people, when we're talking about surgery, when we're taking sections of the stomach out, we're stapling, we're lap banding, this has to be a patient that follows up. You can't just have the surgery and say, peace, I'm out. No, because we're doing malabsorption and different lifestyle changes. There's a behavioral health component that goes people that go through bariatric surgery have to have, and then they also have like a dietitian. So if you have a non-compliant patient, this is not something for them. And then obviously if they're not a good surgical candidate, that we don't necessarily want them to go through this. And then the psych stuff, psych is part of the screening for this. I think this is self-explanatory. Where's the best? All right, so first we have a sleeve. Sleeve, you get 25% of weight loss after a year. That's a lot, right? Again, this person has BMI of 40 or above. So they essentially just cut 70% of the stomach out. Goodbye. So if I lose 70% of my stomach, I'm probably not going to eat as much, right? I'm going to be fuller faster. I lack ghrelin secretion. That's removed. What's ghrelin? It's a hormone. So what do you think? Yeah, it makes you hungry. Think of, do you guys see the movie Gremlins? You can feed the gremlin after midnight. Anyway. Okay, so gremlin is hungry. So that usually goes away. It's not reversible, right? You can't just like slip that stomach right back on. And it's not done as often anymore, but these patients definitely will have reflux, because that, look how little, my stomach's only 30% of the size. So reflux, and then they have less likely to have nutritional deficiencies because their small intestines is still all intact where it has been, okay? So that's your sleeve. And this is your gastric bypass, 30% of total body weight after a year. And this one, they essentially just, they cut the proximal part out. Here, they staple that off at the top. And then they bypass, they just essentially gastric bypass. They cut, and then they bypass, and then they attach over to the small intestine. So you can't eat as much, right? Because your stomach has decreased. You're going to have nutritional deficiencies. So these people, turns out the small intestine is pretty important, right, for vitamin absorption and other things. So you have to caution they're going to be on vitamins and things like that. What do you think dumping syndrome is? Dumping. Okay. Again, most likely not reversible. Okay. So leaky stools, I guess. Okay. All right. And then the last surgery is lap band. This one, 15 to 20%. And just this year, FYI, the FDA approved it for BMI 30 to 40 with one obesity condition. So they lowered the cutoffs for this, but that's just FYI. So essentially they do surgery and they put this adjustable band around the top of the stomach, and they adjust, I guess, the tension or stricture. They can adjust it, and then obviously if it's reversible, they can remove it. When I was in I don't know, 10 years ago, this seemed like a lot of people were doing it, but it's less common now, I guess 1%. But it seemed like this was a little bit more popular in the past, but it just doesn't seem to work that well compared to other surgeries, and maybe I think there's like surgical risks and complications that are significant, and lots of follow-up, right? So here's a comparison of each. Okay. So we get significant weight loss up to 75%, 40 to 75% is possible. If we have that percentage of weight loss, especially someone who's like BMI is like 60 or 50, but technically we can refer them if it's above 40 and they're interested in discussing it. We're going to lower the risk for all these other comorbidities and cardiovascular stuff. Okay. All right, complications, stenosis, leakage, sepsis, and kind of like surgical risks in general, reflux, the dumping syndrome where that undigested food moves too fast and you get the diarrhea, so it's like pooping, but like you're not getting nutrition, gallstones, wound problems. Don't memorize this. It wouldn't be like, what are complications? It's just understanding, I think, the overall concepts, not the nitty-gritty, okay? It'd be a piece of the puzzle. It wouldn't be something I would include. All right, the last thing, and then I promise. No, wait, we'll pause here and come back after, and we'll end this in 5. Okay. So yes, it's a huge thing. Like, look at all these benefits, pros, right? You're really making a big difference, but there's a cost, right? Still surgery, still that. But TRICARE covers this for who? BMI 40
higher.
or 35 with comorbidities. Awesome. Do I have to be on a GLP-1 to be a referral? No. We need to just show that I've done diet and exercise, which is it's a little subjective, right? It's what the patient tells you, but they've tried diet and exercise and it's failed. The lifestyle stuff. Okay. This next section to me is fun. Their treatment gaps. So it's someone who doesn't meet qualifications for like for a surgery, or they're maybe they don't want something as aggressive as surgery. So there's these cool, I guess. Oh, not all of them are cool, but there's these options or devices. Some are FDA approved, and they're minimally invasive, but they don't necessarily. Patients might get it and pay for it on themselves, so they might not go through you to get them. So just more awareness that these things exist. So the first treatment gap is the Obera or Oblong, I'm probably saying this wrong, but intergastric balloons. So it's kind of like, not quite the same as a physical GLP-1, but again, they put a balloon in the stomach, and then what, does that make sense? It assists with satiety, and it helps, so you're going to get fuller faster, and it stays in there for 6 months. It's reversible. So maybe easier than gastric bypass. And then there's this guy, Esprit Assist. It's an aspiration device. So 20 to 30 minutes after you eat, you can just eliminate 30% of your food into the toilet. Gross. Yeah. Anyway, it exists. It's a thing. Yeah. Yep. Do you see these are all FYIs? Okay. Then you have plenty. Do you guys have, you know, the stress balls, the Orbeez with the little, this is what my brain thinks of, so I added the picture, but it's probably way more complicated than that. But essentially, you take these, there's these capsules that are super absorbent, and you eat them before you eat, and then it helps you feel full. It's a really blurry picture. Sorry. But anyway, it fills you up. I don't know how that passes though. There's that tool. And then there's this transpyloric shuttle device, endoscopic procedure, so definitely not as invasive as going under general anesthesia. And then it assists with fullness and stays in there for about 12 months. All right. You guys know this already. Who do we consider a referral for?
30.
Over 30. For obesity medication, over 30 or over 27, and that's the same with the obesity referral to medical specialists. And then the bariatric surgery is 40 or 35 for weight-related comorbidities. All the things we talked about. We have one case, and then we'll go into diabetes. All right, so we have a 26-year-old female presents with infertility. Lenora Grant. Okay, she wants to get pregnant, but she's been unsuccessful for the past 2 years. She also wants to lose weight. So she actually came in talking about weight, but a lot of times patients don't. Past medical history, what is that word? Oligomenorrhea, what is that? Light menstrual cycles, irregular menstrual cycles, usually light. And she has a family history of diabetes, type 2, I don't know who it is. Oh, both her mom, and the strokes. Her mom has a stroke and type 2 diabetes. So we do a physical exam. What do you see, what's her BMI? What class is she? 3. Yeah, class 3. So why? Class 3 is what? When does it start? 40, yeah. Perfect. And so physical exams unremarkable. There's your cue if you forgot. High fives. What do you want to do? We've got a good history. That's all we got from the history. What should we do next? Physical exam, unremarkable. Let's do some labs. So because we're in Endo, right? It's always labs. So luckily these labs are very straightforward. There's no stimulation tests or anything like that. So we check her thyroid, it's normal. What do you think of the fasting blood glucose? It says it's high. I don't know if that's diabetes high yet, but we know it's high. Total cholesterol is high. Triglycerides high. LDL is okay. HDL is 42. So in men, we want HDL above 40. Think of the happy, healthy, heart-healthy cholesterol. We want it higher, the better. And for women, it's supposed to be 50. So what are the 4 issues, diagnoses that this person has?
Insulin resistance diabetes.
What's she coming for?
Wants to get pregnant.
She wants to get pregnant, yeah. What else can we diagnose her? Now that we've done the obesity lecture, what can we diagnose her with? Obesity, right? Yeah. And then maybe what do you think of her cholesterol? Is it hyperlipidemia, hypolipidemia? Is it just fine? Maybe some hyperlipidemia, and then the elevated fasting glucose. So what is our plan for her? Specifically with number 1. So BMI 44. Yes, we have lots of things. First, lifestyle, right? What kind of lifestyle stuff are we talking about?
Exercise.
Nutrition. What else with nutrition? I mean, eat healthy. What helps me? Yeah, exercise. What else? How do I maintain? How do I keep this long term? What do I have to change in my day to day? My behaviors, right? So behavior modifications. What referrals can I do for this person? Nutrition, dietitian, awesome. Obesity specialist maybe, and then can we send this person to bariatric surgery if they want to? Yeah, we could. If we know from their history they've actually tried diet and exercise and failed, can this person be on medication?
Yeah.
What meds would phentermine? Can we give her phentermine? Why not?
She's trying to get pregnant.
She's trying to get pregnant, yeah, so that would be cautious. Kind of all of them will be cautious if she's trying to be pregnant. So we probably attack the fertility for sure. Let's say she's not trying to get pregnant. Which meds can we give her? Phentermine, yeah. We just have to caution her about the side effects with phentermine. GLP-1s too are an option. So this is what our plan is. We're going to repeat fasting glucose and order an A1C. We're going to follow up her labs. We're going to screen for PCOS, which you guys will learn all about PCOS too next week. Dietitian, you guys got that. Exercise, we've got that. We're going to discuss health risks, right? Excess weight. We're going to discuss obesity, discuss it as far as like the comorbidities and why it's important, and have her follow up specifically for it. We can consider meds or a referral. Does anybody know about the SAD diet? Yeah, this is the SAD diet, guys, versus the Mediterranean diet. Poor America. Anyway, but there's people who eat like this, maybe not all the time. You can have this goodie sometimes. But again, you see the difference between the SAD diet and the Mediterranean diet. Any questions about obesity? Okay, so it's pretty straightforward. Maybe by now you believe me. Okay, so we're going to part 1, diabetes. Okay, so usually there's a day, you get a break from hearing my voice for a day, and then we go into this. So I added this last semester because I don't want to like obesity is very simplified, but remember, we have all these GLP-1s. You know you can refer to surgery, but remember like the value of food and like really good food, and that there's nutrient dense and all of that stuff. But like food and exercise, lifestyle stuff, there's a reason we still recommend that, and it works. So food, don't forget, food is medicine, can be. But this is what our patients have to deal with, right? So this is from 2023, not from current. I took it from a study. And so these are all the different influences affecting your patients, you guys, all of us essentially, all these factors, right? So you have individual factors, age, ethnicity, genetics, right? We know it. Behavioral factors, social culture, community. Is my school environment, what are school lunches like? So good, right? Maybe they're better. I don't know. Maybe I don't know. I haven't been. But what's my economic stuff, that sort of things. So there's lots of factors that go into it. And then you add people talk about macros, keto, all of these things. So it's just really overwhelming for your patient. Do I need to be gluten-free or do the zone diet or what are these? Paleo I've heard of. There's probably someone here. Intermittent fasting. That's good. I don't know what a flexitarian is, but I don't know. Anyway, so there's just a lot out there. I don't know what HEI is, but there's a lot. So you guys, I don't teach you which way to go, there's not enough time for you to learn all of these things, but you kind of have to learn it on your own when you're in a clinic. And I encourage you to prioritize food and to look it up so you can help your patients, okay? And then this is just, it's from 2021 study, Sprickley study, and it's a systematic review of people who were successful in weight loss. And it was like based on their perceptions and qualitative data. So what works? Self-monitoring, setting goals. So they have to be an active participant like in their healthcare, right? And then obviously external monitoring, so that like social stuff makes a big difference. Okay. So again, obesity is easier on my endo test than it is in real life. Okay. So a 42-year-old female presents to the clinic for hypertension follow-up. She's 5'6", 192 pounds. Her BMI is 31. What is her current obesity classification according to the World Health Organization?
C.
A, B, C, or D?
C.
C. Even on a Monday after a test, you guys are it's a fairly straightforward question, right? Okay. According to the National Institute of Health Clinical Obesity Guidelines, which of the following represents the correct choice for the initiation of weight loss medication?
D.
I hear a couple D.
Awesome.
Good job. D, BMI over 30. Has BMI over 30 or 27 with weight-related comorbidities. So let's break that out. Hyperthyroidism, not a relevant one. Osteoarthritis is a bummer. We're all getting it, but not relevant. And then 25 with hypertension. Hypertension is but I'm gonna rescue 27. And then UC, ulcerative colitis. You guys know what that is now, right? That's also a bummer, but not related. So again, these are kind of like straightforward questions. So it doesn't take a ton of time studying, but it's nice not to miss, right? Okay. All right. Which of the following is a contraindication for the use of weight loss medication? Osteoarthritis, hypothyroidism, type 2 diabetes, mild depression, or uncontrolled hypertension. So I would make it really clear. I can see why B would be potential because these are psychiatric disorders, but for sure that uncontrolled hypertension. So I would make that very clear in the test. A 42-year-old female presents for a 4-week medication follow-up. She has failed several attempts at weight loss with lifestyle changes and was started on methamphetamine last month. She has noticed weight loss, but complains of dry mouth, restlessness, and difficulty sleeping. BMI is 41. She has no comorbidities. Which of the following is the most appropriate step in the management for this patient? We'll say we're taking her off phentermine. What do you want to do now? Based on the options, you might do something else. C? Any? Okay. Good job. C, gastric bypass. Because based on her BMI, she's tried meds, she's tried lifestyle. Orlistat, Allie, what does that do? She's over the counter, oily stools, it's only at 3%. Levothyroxine, are we going to give her thyroid meds? No, she's not hypothyroid. I would have she's not at all. Grapefruit diet, are we going to ever recommend that to our patients?
No.
Probably not. And then plastic surgery, why am I not just sending her plastic? That might be after the weight loss. That's usually out of pocket. Look at that. Okay, we're moving on. Ready? Set. You still with me? Okay. Diabetes part 1. So this is a big topic for endo. I have not one, but 2 slides for objectives. This first lecture kind of talks about type 1 versus type 2, prediabetes, that diagnostic lab, that sort of stuff, and then we dive into medications. we'll get through what we can get through. And then tomorrow, bright and early, we talk about complications. So that one's neat. All right, most of this is review. If I go too fast, like wave or something. Okay, so almost 40 million people in the U.S. have diabetes. I guess 38.4 is the estimated. So it's 12% of the population, of the United States population. Now, do most of those people have type 1 or type 2? Type 2, right? Only 5 to 10% are type 1 diabetics. Okay, the remaining is type 2. Current data is 37.3 versus the CDC is 38.4. So again, it's estimated. And the table right there kind of breaks it up into age. There's also a lot of data on like cultural factors, ethnicity, race, that sort of thing, sex, all of those things. There's a lot of data on diabetes. And then of course it costs money, right? $1 every $5 of healthcare is spent on caring for a person with diabetes. So don't just care about it because we're in Endo and we have to think about it for the test, but yeah, it's a huge thing that you will see. And then just terms, diabetes is excessive urination, insipidus is our tasteless, we already learned about GI, mellitus is the honey or sweet. We do not taste urine anymore, thankfully. We're gonna go through the labs though. How do you diagnose it? Just a few slides. So, what organ is this? Oh, it's the pancreas. I have it right there. So we have the pancreas. The pancreas is super cool. I don't know how much GI gets into it, but a lot of what the pancreas does is GI and digestive enzyme related. The exocrine stuff, we're only going to talk about the endocrine hormones, okay? And how it plays a role in blood sugar, okay? So, insulin, what does insulin do with relation to glucose? Yeah, it lowers it, right? It helps it get into the cells so it can do what it needs to in the brain and the muscles in the cells. What about glucagon? Yeah, it raises, it's the opposite, right? So we'll dive into those two in a little bit in the next slide. What about, anybody remember somatostatin? It inhibits growth hormone, but it kind of fine tunes the glucagon and insulin relation. So it's kind of a fine tune. Pancreatic polypeptide. Any guesses on that one? So I don't really care about it, but it has to do with GI mobility. And then gremlin, you guys already know, right? The gremlin, it helps with hunger. It's related to hunger, excuse me. I don't care if you know where the cells come from. Really, the only ones I think are important to really understanding diabetes is insulin and glucagon. And I'm going to you learned about it in pathophys. I have the next slide breaks it down. Just need you to have like the awareness in the background of how insulin and glucagon work, especially related with when we get to complications. So DKA is the big one. Okay. Again, we need insulin. You guys all know that. We need insulin for glucose to work. My body, our cells need energy, right? And we get that from glucose. The brain loves sugar and it needs it, right? Yeah, I think that's all I need to have. You guys good with that? Good review? Okay. Insulin lowers glucose, right? Facilitates that glucose into the cells where it can be used to work. Glucagon raises it, right? Specifically with the liver cells, promotes gluconeogenesis. The blood glucose balance is key with these two lovely hormones. Questions on that? Review? Yes? Yeah? Okay. All right. So, definition time. Diabetes is a syndrome of disordered metabolism and inappropriate hyperglycemia. And it's either due to deficiency in insulin secretion. So my body no longer makes insulin. That is a problem, right? Because we know that because we need glucose to get in the cells for me to live, to function, all the things. Or it's a combination of insulin resistance and inadequate insulin secretion to compensate with that resistance, right? So in both states where glucose is what? It's high, right? Hyperglycemia. Which one is type 1? The deficiency, right? It's an autoimmune disorder where my body no longer makes insulin versus type 2. There's a few other specific types we'll introduce. Definition for prediabetes: impaired fasting glucose or glucose tolerance. So this is that gray area. I introduced the preclinical obesity that's new in medicine. This is maybe where I think about it potentially, but it's a prediabetes. It's like warning, you're on your way to diabetes. Diabetes is not a good thing. We're going to attack it early. So when you have a hemoglobin between 5.7 and 6.4, that's an actual diagnosis, prediabetes, where you're going to draw attention to it, and you're going to start potential treatment. The coolest thing about this is if you decrease body weight by 5 to 10% through exercise, lifestyle, or sometimes through medication, it prevents or delays development of type 2 diabetes. So if you have a motivated patient and their A1C is like 5.9, jump on it, right? And then we want to prevent diabetes, especially if they have a family history of someone in their family who has diabetes. That might be more motivating to do it as well. Prediabetes is also associated with metabolic syndrome, which we'll jump into. So this table is a nice comparison of the two. So when I talk about type 1, have it in purple. When I talk about type 2, it's in red. And again, we know the population already. Let's look at this together. So population, type 1 is 5 to 10%. Most of the population with diabetes is type 2. Age of onset, very different, right? Usually for type 1, they're young. They're 10 to 14 years of age. Technically, you can have adult onset type 1 diabetes. I had it in one patient at USAFA. His son had type 1 diabetes, and this guy knew he had it. He just didn't come in for a long time. But so it can still happen as adults. But how is type 2 differently? They're usually older, right? Over 40. However, remember what we just talked about in the obesity lecture, is we're getting bigger earlier, right? So type 2 can happen before 40 as well. We know this pancreatic function, there's usually none, right? The pancreas lost its ability to make insulin versus insulin's present, but we're resistant, right? It's not working. Or we have too much glucose in the body to kind of like get that homeostasis. Autoimmune versus non-autoimmune, right? Family history. When do you think family history is stronger, type 1 or type 2? It's type 2. With really strong history is in type 2. So type 1, you don't have the exact like genetic marker of why some people get type 1. But yeah, so it's really family history of type 2 diabetes is a really strong indicator. Obesity, type 2 it's a big deal. It's the most important environmental factor for those with type 2. So 60 to 90% is a big gap. People with type 2 are obese. Now, again, type 1 patients can be obese, but usually if they don't present in emergent DKA, they're going to present with weight loss, not weight gain. Ketoacidosis is more common in type 1 than type 2. And then the polyuria, polydipsia weight loss is that classic type 1 diabetic presentation. Versus, do you think type 2 come in and say, I think I have type 2 diabetes? No, you just catch up in a screening lab. I swear, most of the time it's asymptomatic. And then insulin is required for every single type 1 diabetic, and for some type 2. We have better meds now, so we're using less insulin, but it's still an option for type 2, especially. All right, so again, destruction of pancreatic islet cells. The beta cells are destroyed. It's autoimmune. It can happen really suddenly, and this is what's scary. If you ever have if you have a kid with type 1 diabetes, or you're a friend of a kid who has type 1 diabetes, it's really scary. So they present really, really sick. Or it could be more of a progression where they have the polydipsia, polyuria, and gradual weight loss. Okay, present year 1. Again, 10 to 14 years of age, and they require insulin for survival. Ketosis is the scary, scary complication we have to educate them on. Same with hyperglycemia. What year do you think we started using insulin?
1972.
19 what?
78.
So younger, earlier. What else? What else? What else? Not 19, earlier. Another age. Has it been around for 100 years? 200 years? What do you think? 1900s or 1800s? 1922 is they did like a study with dogs and insulin, but 1923 is when it became mainstay. So over 100 years, we've been saving people's lives. Before we started using insulin, what happened to type 1 diabetics? Yeah, they didn't make it. So very existential thing. Type 2, typically older. Again, talked about first, but the key difference is this one is autoimmune disorder, destruction of the islet cells, versus insulin resistant with beta cell loss and dysfunction, right? The pancreas still works, at least for a while, and obesity is the greatest risk factor, right? Especially where that visceral obesity, in the organ obesity, okay? And then I have the picture of the active duty, so you will run into active duty with this. This too, my old commander had type 1. And he was still in. So FYI, there's other types. Mature onset diabetes, it's kind of like they don't quite fit type 1 or type 2. There's the latent autoimmune, the LATA, that exists. And then remember all the things we learned about last block, right? Cushing's, acromegaly, right? These patients can present with type 2 diabetes because of that excess cortisol, because of that excess growth hormone, right? So there's secondary causes for hyperglycemia. So we fix that, we can potentially fix the diabetes. Also PCOS is death out. Questions? Good intro? Good review? I talk about diabetes all day. Trying to be metabolic syndrome. So this, we talked about, you learned in cardiology, yeah? All right, so no waist plays a role, waist circumference, because we talked about that in obesity. What else plays a role in metabolic syndrome? There's 5 things that we look at when we're diagnosing metabolic syndrome. Anybody remember? 5 things? Blood pressure and waist. We got 2. What else? What else? We're in the diabetes lecture. Triglycerides, fasting blood glucose, and HDL. Okay, so we have it's a cluster of these metabolic related things, and you need 3 out of the 5. Most of the time, people have all 5, or 4 out of the 5. But it's an independent risk factor for cardiovascular disease. Okay, now if someone has full-blown diabetes, that's a whole other thing. This is like that impaired fasting blood glucose, hyperlipidemia, potentially hypertension, and central obesity. Right? The people who are obese, eat that sad American diet, don't exercise, are the most risk for this. Okay. And then here's a little table. That's good to know, probably. Symptoms review. We have our 40 to 35 inches for waist circumference, triglycerides over 150, HDL, blood pressure, and fasting glucose. It's associated with insulin resistance, should be no surprise. You kind of are this like pro-inflammatory state where you have like thicker endothelials and increased risk for blood clots and that sort of thing too. Gout. That's it. All I need to know for metabolics. All right, so we're moving into clinics. So signs and symptoms. So what are signs and symptoms of type 1 diabetes? My autoimmune, my pancreas fails to produce insulin hormone. How do I present? Polydipsia, what else? Yeah. And I could be, what's my medical emergency, do you think? DKA, which don't worry if you didn't know that, you will tomorrow. All right, so polyuria, polydipsia, polyphagia, they're hungry all the time, but they're losing weight. And again, it's this loss of glucose, they're peeing, they're have excess urination, they're dehydrated. They get blurred vision because that hyperglycemia, all the sugar loves the lens, or the lens loves sugar, I should say, and so they can have blurry vision. And typically it resolves when you give them what they're missing, which is insulin. But again, this is that picture of your type 1 diabetic. You have hypotension, paresthesia, so it's the neurotoxicity. Again, excess sugar messes with the lens of the eyes, messes with the nervous system, and then ketoacidosis. We're going to talk about that in a lot of detail on part 2, but this is a medical emergency. And again, how so many kids present. And then obviously if I don't have insulin, my brain doesn't get glucose, so then my level of consciousness is altered, and then I could go into a coma or die, right? Versus type 2, most commonly asymptomatic. They just come in for their blood pressure renewal medication and their annual labs. It's found incidentally when you do a CMP or an A1C, so your wellness labs. But we also know obesity is the most common risk factor, so we're going to waist size or BMI can be an indicator. Sometimes you'll catch this in women who are pregnant. So during the screening labs when women are pregnant, you might catch this either from the oral glucose tolerance test or maybe baby size or other things that happen. And we'll talk about the last thing tomorrow. Skin findings. Chronic skin infections are really common, especially like in the overlapping skin. So like with obesity in the folds, you can get skin infections easily, especially if you're a diabetic. Pruritus, vaginitis, so like yeast infections. Usually if you have someone with like a yeast infection, it just keeps coming back. You may want to screen for diabetes. Acanthosis nigricans, do you guys know what that is? So it's darkening, I have a picture, it's darkening of the skin. It's related to insulin resistance, and it's going to be in creases. So you're growing your axilla, you see it on your neck. So when you're listening to someone's heart and lungs, I'm always looking, when I listen to their lungs, I'm looking behind their ears and stuff for moles. But you're also looking for, we can look for acanthosis nigricans, which looks like this. Also, you can have this eruptive exanthem, and it's on the extensor surfaces, and they're just like small, like yellowish, reddish papules that you can see, and it's related to high triglycerides. High triglycerides, high sugar, right? The hyperglycemia and high associated with the hypertriglycerides. Very different, yeah? This guy is different than this guy. Here's a picture of the examples. Here's a table if that helps with the comparison. All right, so we've done our history, we've done our physical exam. Now let's do the labs. Any questions? Okay. Do you like these labs? Maybe. Maybe. Okay, shouldn't jump the gun. All right, so let's talk about this for just a second. So any abnormal lab should be confirmed on a different day to make the diagnosis of diabetes. So does that kind of remind you of hypertension? So you can't just diagnose hypertension on one elevated blood pressure. Well, the rules still are similar with diabetes, that you need more than one lab to diagnose diabetes. But if you have a patient and you ordered a fasting CMP, which is where you get your fasting blood glucose, and you order an A1C on the same day, that counts because it's two separate labs, okay? So that's essentially what that says. You don't have to do a fasting blood glucose and an A1C. You can, there's other options too, but those are just like the easiest that you would do. So either repeat it, get a high A1C, you're going to repeat it later on, or you can do a fasting blood glucose and an A1C at the same time. Both are elevated. You have diabetes. All right, so here's your criteria. So fasting blood glucose over 126, an A1C over 6.5, a random glucose with signs and symptoms of diabetes over 200, or a 2-hour oral glucose tolerance test. These are the only, you gotta know these. Okay? You gotta know these for the pants, you gotta know these for life, for the PCM. But we'll practice a lot. There's a whole lab you guys will remember. I'm just going to tell you, I don't remember the last time I ordered a 2-hour glucose tolerance test. So I don't order it that often, probably care that much about it, but you still need to know it's a criteria for diagnosis. Here's a table, if you like that better. Same thing. Okay, let's talk about the lab. So a CMP gives you your fasting blood glucose, or you can just order the lab itself. So fasting, that means you fast, get labs in the morning. Here's your range. Over 126 is diabetes. Okay. If I do a random, so I'm non-fasting and I have symptoms of diabetes, maybe I have central obesity, or my waist circumference is high, I have obesity, I have some skin changes, then that, and the random glucose of over 200. Usually you get your random glucose when you're in the ER, you go for something, or you get non-fasting. All right, hemoglobin A1C, or glycinated hemoglobin A1C. There's a lot of words to just say it reflects your blood glucose over the past 3 months. So it paints a picture. And so if I get one fasting blood glucose on Tuesday, cool. This paints a picture for the last 3 months. This is my favorite lab to order because I use it. You'll see in the lab, you're going to use it to adjust people's medications and taper on or off medications and doses. So you don't have to be fasting for it. But again, it's used for screening for diabetes, pre-diabetes, as well as diagnosing. So if I have a diabetes over 6.5, or sorry, A1C over 6.5, then I'm worried about diabetes. Now, there are people, especially with different anemias and things like that, where you have to maybe repeat it or do a different lab. People with like chronic liver, kidney disease, you may have to, A1C might not be ideal. But for the vast majority of the population, A1C works. At the very bottom, it says PA heaters, January labs. Why do you think an A1C in January would be different than an A1C in March? Holidays. Yes, we're in it. So the holidays. So if I check labs, they had to survive Halloween, Veterans Day, I don't know, all the free food and Veterans Day, I don't know. Thanksgiving, Christmas, New Year's. That's a lot of yumminess. So that I'm very aggressive when I treat diabetes. And you'll probably understand why soon. But I'm very aggressive in it. But that January labs is the only time where I'm like, okay. Or if they just were inpatient, and when they go inpatient, sugars get messed up. But again, just remember the last 3 months, hemoglobin. And these are variants. I do not expect you to know. I just need you to know that these exist, but I'm not going to test them. Okay. Okay. All right. So I just love this table. I think I have it in here 3 times. Okay, but related to lab, so 6.5 is diabetes, right?
Yes.
So 6.5 is right here on the axis. Blue is retinopathy, nephropathy is yellow, neuropathy is green, and albuminuria, I can't say, is red. We'll talk about that soon. So this shows the relative risk related to A1C. So if I let my patient hang out at 8%, I have a 3-fold increased chance of retinopathy. If they hang out at 10%, no, I'm going to exercise this month. I'm going to walk more. I don't need higher meds. If I leave them there, they're at a 7% chance of retinopathy. So again, this is the microvascular complications. People kind of think of diabetes, oh, I'm going to lose a foot or things like that. No, it's the small cell damage that happens first. And it's happening when they're roughly between 7 to 8. So if I have a 45-year-old male, I'm going to be really aggressive because I want to prevent all of this stuff. Okay? So again, why A1C in relationship to complications. This is such an old slide, but it still stays. Right. So here is your hemoglobin A1C value, and it is associated with the average blood glucose during those 3 months. So if A1C is a 5, maybe my average blood glucose over the last 3 months was 97. Versus a 10, my average blood glucose was 240. I have seen 13, a diagnosis, and they were less than 50, asymptomatic. Both of them. They're actually, I combined them into my lab. And then corn syrup, if you get 14 or higher. Okay.
Every morning for breakfast, Pixie stick.
Oral glucose tolerance test. So you can consider this. It's a tool in your lab tools if you want. Like I said, I don't order it. A lot of times this is done in pregnant women. Has anybody had this before? Anybody? So I did it when I was pregnant for screening with my first kid, and then I was in a medical study in PA school that paid me and it fed me. And I had to do this, and it's gross. They give you, so you fast, and then you give this like sugary grape or orange. It does not taste like grape soda. It is gross and super concentrated. You drink it and then they track your blood sugar a few hours later. Okay, and then abnormal is if it stays high over 200. Not ideal. Who has 2 hours to like give up to this, right? Not a lot of people, but again, it's a tool in your tool belt to diagnose diabetes. Okay. Serum fructosamine, I never ordered this one, but it's similar to hemoglobin A1C as far as like it's another biomarker, and it correlates with your average blood glucose over the past, like, this isn't 1 to 2 weeks, but almost like 2 to 4 weeks. And so maybe you can use it if they have some kind of anemia. You can use this instead of A1C. I don't need you to know the details of the range. Urine. So urine should be really important, right? We're talking about diabetes mellitus. It's talking about urine, sugar, urine. Luckily, with these blood tests we have work so much better. So we can use urine for someone who has diabetes, but urine is not used to diagnose diabetes. Okay? So not for diagnosis anymore. But if I'm dumping a lot of urine in my, a lot of glucose in my urine, that can be a signal that something's going on. But other things can cause glucosuria too. Ketones are a big thing, especially in our type 1 diabetics. When they get sick, we monitor urine ketones because that can be associated with ketoacidosis. Okay. So again, helpful when people already have diabetes, not used for diagnosis anymore. And then insulin, we don't, so all our insulin is like PCOS patients, but it's not diagnostic. And then C-peptide is another tool. They should meet, C-peptide should mirror endogenous insulin levels. Yeah, I'm not going to test you on it, but it's a tool that you could order. And then autoantibodies are for type 1 diabetics. Okay, so if you have a kiddo who comes in, they're 12 years old, they're drinking a lot, eating a lot, peeing a lot, but they're losing weight and they're struggling, you're worried about type 1 diabetes, you could also order these antibodies, okay? It's just when I ordered, I don't think there was a panel, so I'm not gonna, I had to look up all the antibodies when I was in clinic, so there's all of them. Just know type 1. Am I doing antibodies for type 2? And the only time maybe it's really hard to control or something, but, or really late onset, I don't know. But rarely now. All right, back to this again. I just swapped it. So your diagnostic labs: fasting blood glucose over 26, A1C, random glucose, oral glucose tolerance test. Know those. Okay. Put the slide in 2 times. Not 2 times, like 3 times. Okay. So another table if you like that better. And again, going back 1 slide, you have to have 2 abnormals, either on a different day or same day. Typically A1C and fasting blood glucose. But it can be any of the 4. Okay. And we came back at 5 after. We'll go 5 more minutes. I'm teaching at 15:02 in case the schedule. I switched with COLA, so you get me. we're doing all the things today. Okay, so Cola will be, she's teaching on Wednesday, I'm teaching it. Okay, so do you want to break now? Or let's do a break now and we'll come back at 3. Maybe we'll be done in 50 minutes instead of 2 hours. Okay? That's my goal too. But I can stay, again, like I said, I can stay till 5. But we can do this. All right, so we are on self-management. What do you think the cornerstone of self-management for diabetes is?
Lose weight.
Yeah, how do we lose weight? Exercise, diet, right? Behavior modifications. Well, we just learned this in our obesity lecture like an hour ago, right? So again, those therapeutic, they have their own title, therapeutic lifestyle changes, right? Lifestyle changes is a big thing. Dietary, physical activity, behavioral changes, stress management, sleep. People forget about sleep. Sleep is so important. Medical appointments, a lot of people talk about all that stuff as we go. But it is always, it would be the cornerstone, the first line treatment, the last line treatment, anything in between. Okay, I'm not joking. It works. Unfortunately, it doesn't work for everybody alone, right? So that's why we have medication. But we always need to remind them how important lifestyle stuff is, because yes, we have these amazing meds, but in combination with healthy eating, it's a win-win. 5 to 10% weight loss and decreases insulin resistance, right? That's the cornerstone for prediabetes too. It reduces all the risk stuff. And then we need our patients to move and find something they like and start doing it, right? Motivation is key. When their A1C goes down or they tell me they're walking or doing some kind of like 5K or doing some gym or something, congratulate them. And my congratulations is genuine. Right? I'm really excited that they're moving and making the right changes. So, diet is really important. There's mixed data on diet, like the ADA. All these different associations have their one thing, but overall, it's just like more real food, right? Less processed foods. Current has this breakdown of macros, which makes me shake my head. Because if you know anything about macros, a 10 to 35% protein percent, that's a really big range. And it's really hard in the standard American diet for people to get anywhere near 30% protein. But again, I push protein, vegetables, all of that stuff, prioritize that. But it's hard enough to get someone to eat like 0.7 grams or 0.8 grams of protein per kilogram per day, let alone 1.5. But again, they're prioritizing protein. Mediterranean style diet is the most #1 diet for improving glycemic control. We want fiber because it helps with their cholesterol as well as their diabetes as well as their stools, right? If people are pooping, you're a little bit less angry, maybe a little less road rage out there than those constipated breakfasts. And then obviously whole grains, vegetables, all these things help with the insoluble fiber helps with movement. Okay, so protein, real foods. This is a breakout of the glycemic index that I alluded to. Again, lower glycemic index foods have lower glucose, so that's like real fruit, real vegetables, like your complex carbohydrates, versus high glycemic white bread, white rice, candy, chips. The scale contains everything to white bread, which is essentially you eat white bread and your body reads it as sugar, as glucose. So it's a comparison. So teaching people to eat low glycemic index foods, then they can Google it, or there's charts and it tells them, oh, this is exactly what I need to eat. Low fat or non-fat. Why is that scary? Why is that not so great? It says hidden sugars a lot of times. In the 90s, there's this big no fat, low fat food stuff, and we think that contributed to the obesity challenges of diabetes, right? Because they're like, I can eat it, it's low fat, but what does it taste good? Why does it taste good? I don't know, probably because of all the sugar in it, right? So remember, sugar is sneaky. Alcohol, kind of a no-brainer, right? Simple sugar. If I drink, I tend to eat a lot of unhealthy foods too. With your type 1 diabetics, and they drink, they have to be really cautious of drinking on an empty stomach, right? So maybe young kids do that. Young adults. might do that. But yeah, you have to caution your diabetics about that, especially your type 1s, because they can go hypoglycemic. And then should diabetics smoke? No. Smoking cessation is key. If you have a diabetic who smokes, spend a couple minutes to foot stomp that they should quit or encourage them. But I can tell them to quit all I want, right? What's going to be the deciding factor? Them. They have to do that. Has anybody heard of nurse diabetes educators? So they exist in the Air Force and in endocrinology clinics. I don't know. I know they exist in the Army, but I'm not sure if they're embedded in the primary care or just in their specialty clinics. But these are nurses who are trained on diabetes. In the Air Force, they also talk about like their disease managers, so they talk about cholesterol, hypertension, and all that. But these people are key, or nurses are key, because how much time do I have with my patients? 15, 20 minutes, right? So how can I go over blood glucose testing, medications, lifestyle, all of that in 15 minutes?
Quickly.
I don't do a good job, right? So if I diagnose someone with diabetes, then I set them up with the nurse educator. They're going to show them how to monitor their blood glucose. They're going to talk about injectables. They're going to get them in like a weight loss food class and things like that. So utilizing your resources, you can also utilize your pharmacies. They can help with polypharmacy with patients on a lot of medications. Okay, so really, really helpful with home monitoring and part of your treatment plan. Blood glucose testing, the finger sticks. Essentially, we're just checking glucose throughout the day, right? Before meals and after meals. Does every diabetic, when you're in clinic in a year and a half, you have someone with type 2 diabetes, are you going to give them blood glucose testing? Have them check their sugars? What do you think? Yeah? Okay. What do I do when they come back and I give you blood? I think it's a good idea. What do you do when I'm like, I've been checking my blood glucose, here's my data. What do you do with that? Use that? So you're going to use the A1C with type 2. But every patient who has type 2 diabetic, I give them the blood glucose testing. Because I want them, it can be a tool to be like, when I eat this apple pie, oh, my sugar goes here. Versus when I eat, squash, or a salad, or chicken, my blood sugar is here, right? So it kind of can help paint the picture of what's happening with their sugars when they're eating. So yes, I give all of my patients blood glucose testing, but it's really, really, really crucial for our type 1s, but not as valuable with type 2 as far as treatment. But we give it to everybody. Urine glucose are not reliable for self-monitoring. Continuous glucose monitors, I think those are like people who aren't diabetic wear those nowadays. Insurance covers it for all type 1 diabetics. For type 2, it varies. You could try. They have to be really uncontrolled, but you could still try. Or they can buy them themselves. But essentially, it's just continually monitoring your blood glucose. It monitors when you eat, also when you exercise, when you sleep. So that allows the patient to see kind of what, like habits. I think the blood glucose testing helps with behavioral stuff and habits. So really helpful for a motivated patient. But if I have an unmotivated patient who already feels overwhelmed, they're going to cut something. I'd rather them cut this than cut this than like their medication, right? Does that make sense? Okay. Now we're going into medication. Who wants to teach it? You guys? Did you teach as a group in farm, or how did it go?
Groups.
It was like groups. Did you come up here? No. You didn't come up here?
Around.
Oh, in my brain you guys were up here. Okay, so I'll just set my expectations. Okay, I'll teach. I'm talking from 10. Okay, so pre-diabetes, weight loss, right? So if we lose weight, we can help prevent type 2 diabetes. So when we have someone with pre-diabetes, we're going to push those therapeutic life changes, and then we have two choices. Are they obese or not obese? So what do I look at to determine if they're obese?
BMI.
BMI, right? So BMI. And if their BMI is normal, I can do metformin. If their BMI is high and they're class 1, 2, or 3 obesity, then I can do a GLP-1. Okay? If I give them their GLP-1 and they lose weight, but they're still kind of at that 6.4, 6.3 A1C, then I might add on metformin. Okay? So for pre-diabetes, the obesity gauge is what I did. This is a table we're going to use for my lab. It's from the American Association of Clinical Endocrinology. It's so you don't have to like memorize and go back stuff. You don't have to memorize all this, or if you forget because you haven't treated a diabetic in a while, there's these algorithms that help you, and they're very nice algorithms. But you see, I have a pre-diabetic at the top. Lifestyle, overweight or obese, yes. GLP-1s, phentermine, consider surgery. Overweight, no. Okay, then let's focus on just the sugar and we'll give them the metformin. Questions on pre-diabetes? All right, so as far as the prescriptions going, the whole focus is the glycemic control, right? They're in this hyperglycemic state, and we want to bring that down, okay? Because of all the microvascular and macrovascular complications associated with my sugar, my blood sugar stays too high. Insulin is for all type 1. Do I give oral medications to type 1s? No, I do not. They get insulin all day. But some of my type 2s may end up on insulin. Here's the classes of meds that you remembered once long ago that we're going to go through. This is the most med-heavy lecture I have because of the pants, and it's just the most common endocrine thing we talk about. So we go to my med slides. You're going to see this is the layout for all the slides. You have mechanism of action, and maybe any key points I want you to know. Over on the right, I'm going to tell you, does this medication cause them to go hypoglycemic? That's a big deal, right? If I give a medicine and I have someone go hypoglycemic, what could they do? Coma, right? Fall. Like, lots of scary stuff happens. Also, and then we've talked all day about weight, right? Obesity. So if I am giving them a med that causes weight gain, that's a big thing. But if I'm giving them something that causes weight loss, that's helpful, right? We have our advantages, disadvantages, and contraindications. I obviously have the type 2 thing here because these are all type 2 medications, type 2 diabetic medications. And then at the bottom talks about where the medicine works in the body. So this is a blow up of it. It's been around forever, but if you're a visual learner, maybe it helps. But it talks about all the ways that different organs play a role in hyperglycemia, and that we know that that's where the medications, we use our meds to attack or work on those areas to counteract the hyperglycemia. Okay, so that's important. All right, metformin, biogonides. Okay, these are kind of our cornerstone type 2 diabetes med. Works through the liver, improves insulin sensitivity, decreases gluconeogenesis, all of these things. We go to the top, we have our advantages, right? It's not going to cause someone to go hypoglycemic, and it may cause some slight weight loss. Do you like that? You're good, right? Okay, awesome. Current says it's the first line therapy for new type 2 diabetics. It says it flat out in there, and you've been saying that for a really long time. You say I have usually. Every now and then, you can use different meds as first line, and I'll tell you what those are. I won't confuse you on the test, okay? This will make more sense when you do the lab. But again, if I say first line medication for new diabetic, it's metformin, okay? Most of the time. We combine metformin with a lot of medications to help control hyperglycemia. Not only does it give me slight weight loss, I don't have to worry about hypoglycemia, but it's cheap. It's been out for a really long time. It can improve my cholesterol. A lot of diabetics have high cholesterol too. So, pretty good medication. On the downside, GI side effects are significant. What GI side effects do you guys remember or think someone would have in that one?
Diarrhea.
Yeah, diarrhea. And it's like you have, so the best way to do it is tell a patient, you take this twice a day usually, and eat it, or take it with food, okay? And it's not just like a half a banana, like it's actual, eat it with breakfast, and that can help. And you can also titrate up slowly, and over time the diarrhea and cramping improves. If it doesn't, there is extended release options, so you could switch it to once a day dosing, and usually that calms the GI side effects too. Big scary thing we worry about is lactic acidosis risk. Thankfully, I've never seen this, but it's one of those, I feel like a board question or metformin. Lactic acidosis and chronic kidney disease with a GFR less than 30. That's what I think of with metformin. So someone who has chronic kidney disease or congestive heart failure, but really it's the chronic kidney disease, I wouldn't give this. All right. Feel good about metformin? Nice little review. All right, now we have our sodium glucose co-transporter 2 inhibitor, or SGLT2s. Talked about these a lot with Dr. Bohr. I think a little bit. Shiv and I were big fans of these and GLP-1s. We nerd out about them. But this one, it works through the kidneys. Okay. When your blood sugar gets like around 180, then that high, then glucose dumps into the urine. So knowing that happens, they use this med to kind of do the same thing. And essentially, we're excreting glucose out in the urine. Okay. It prevents reabsorption of glucose in the renal tubules too. So cool. So how do I remember SGLT2 and urine? Well, Flozin. So they're all the Flozins, right? If I think of Flozin, Gliflozin, and I think flow, makes me think kidney, gotta go. Yeah, so Flozins, SGLT2s work in the kidneys. Coolest thing is the stuff in bold. FDA approved for reducing cardiovascular disease. That's been known for the last few years, excuse me. Unsure if it's a full class effect or not, but Jardiance is the big one related to that. Now if you go down and it says, considered as first-line initial therapy for a new diabetic that also has chronic kidney disease and or cardiovascular disease. So this is when you have a type 2 diabetic who's newly diagnosed and they also have heart disease and kidney disease. You can start with the SGLT2 instead of metformin. That's essentially what this is. Advantages, weight loss. So, yep, in the right corner we get weight loss. And quite a bit of weight loss, not as much as SGLT2s, but you'll get quite a bit of weight loss. And phew, it's not going to cause the patient to go hypoglycemic. And then again, the biggest thing, reduction for cardiovascular disease, chronic kidney disease, progression, heart failure. It's a really big win because these patients often have those things already increased risk for them. Disadvantage, if I'm working through the urine, I'm going to have increased urination. Also a risk of like UTIs, fungal infections, as well. Okay, it does cost more. When I left for my deployment in 09, no, 08, I came back in 09. I think Jardiance was still not on formulary. Or maybe it just switched, and I was really excited that I finally got to use it. But again, they've technically been out for a while, but the cost is improving. Now, contraindication is if somebody has severe chronic kidney disease less than 30, you can't use this, which is kind of confusing because they said it's helpful for people with chronic kidney disease. It's just really based on the severity. So the more severe, you can't use this. Obviously not on a GLP-1, glucagon-like peptide receptor agonists. So there's two in this incretin-based therapy, so GLP-1s and DPP-4s. So they increase insulin release in response to food. So I eat food, I get a more insulin response, and they also help with fullness. And they can help with like overeating, right? So maybe people call it like the food noise, where that urge to overeat goes away. Really, really cool. That helps with obesity, prediabetes, and type 2 diabetes. So again, impacting that hunger. So semaglutide, probably the most common. Nowadays, when I was in school, exenatide or Byetta was new, and when I was in endocrine, I saw the endocrinologist using Byetta or exenatide all the time. It was a sub-Q injection twice a week, and they were also using DPP-4s. When I went into the PCM clinic, they weren't using any of those. So I was like a little nervous that I was doing something different. And I will tell you, whenever I tried to tell a patient or introduce doing a sub-Q injection, they're like, no way, I'm not doing that. And now look, everyone's doing GLP-1s, like no big deal, right? They don't even have diabetes and they're doing sub-Q injections. So anyway, but we've come a long way. Byetta, exenatide, we don't really use that much. It causes a lot of bruising. It's not the best one. Semaglutide, Trulicity, all these other ones are better. But they've come a long way. So they have technically been out for a really long time, but they just haven't been used for obesity like they have until recently. And again, it can be considered first-line medication therapy for a new diabetic who has chronic cardiovascular disease. Cardiovascular disease, not chronic. Advantages, weight loss, sweet, another weight loss one, and sweet. It's hypoglycemic neutral, so it won't cause my blood glucose to tank. And again, it addresses that like overeating. Disadvantages, it's an injection. The first injection we used, said people don't seem to mind it anymore. Honestly, the sub-Q injections hurt less than finger pokes. If you've ever checked your blood glucose, these hurts more than the injections. I know that from a diabetes camp I worked at when I was in high school. I'll just tell you later. Pancreatitis, there's a risk of that. It costs money. The main thing, I'll bring it into the lab, the thing that costs the most money is the injector that it's in. And I have a sample of what that looks like on my desk that I'll bring into the lab. But the biggest side effect that you need to know for your patients is the GI stuff. Nausea, vomiting, diarrhea, constipation. We talked about this in the obesity lecture, right? We're slowing things down. So we have constipation with that nausea, vomiting, diarrhea. And then you can't use it for any patients with MEN2 or medullary thyroid cancer. You guys know what MEN2 is? And medullary thyroid cancer. Okay. The other one in this class is DPP-4. So I used to prescribe these a lot. There's not a huge dip in or impact to the A1C as these other meds, but it's a nice option if they just need a little boost. In addition to like say metformin, we know it's not going to be as significant of a weight loss either. It's actually weight neutral versus GLP-1s. But so we have we know that normally GLP-1 is degraded by DPP-4. So if we inhibit DPP-4, we're increasing the GLP-1 effects. That's essentially how it works. So they're all the gliptins. Januvia is probably the main one that I've prescribed. Weight neutral, so I'm not causing weight gain. That's a benefit. It's not an injection, and I'm not causing the glucose to tank. It's actually not that expensive, so I should probably just drop a couple dollar signs. But you can have like serious like anaphylactic reactions to it, and pancreatitis too. TZDs. So this one, when I was in school, metformin was not super new, but TZDs and sulfonylureas were on the paints. I don't think they will be on there like they were back then. But again, I think so. It kind of increases the utilization of glucose in the peripheral tissue. So that's how it works. Then you can also know that a disadvantage is it's going to cause weight gain, and then a lot of times it can cause peripheral weight gain or edema. Okay, so it's our first medication class that causes weight gain. Right. So do I want to give my obese patient a TZD at the top of my list? No, right? Because it's causing weight gain, and I want my patients to lose weight. Yes, if they're contraindications to GLP-1s, SGLT2s, DPP-4s, this is a tool I can use, but it's probably not going to be the best one. There's just better meds now. But this has been around for a long time. It's super cheap. But again, if I have severe congestive heart failure, or you can't give this to them, and then again, you have to know that it's going to cause weight gain. Almost through. We have secretagogues, so sulfonylurea. Sulfonylurea, you guys talked about this in farm, I remember. Okay, so these ones, they work in, they kind of like, not punching the pancreas, but they like poke the pancreas and make like, hey pancreas, wake up. I need you to produce more insulin. And we've used these for a really long time. Their downfall is they are susceptible to hypoglycemia, especially in sulfonylureas. They also cause weight gain. So twofold, we just have better meds than this. You will still see patients who are on sulfonylureas. They're really, really cheap. They don't actually impact your A1C. These are going to be diabetics who have been diabetic for, I don't know, 15 or 20 years, and they're stable. So you have kind of to decide, am I going to renew the sulfonylureas, or do I do a med change? They're not great. I think Karen used to call them the devil. So again, they play a role. We just have so much better meds, because I don't, especially if I have a 45-year-old and I give them a sulfonylurea, I'm poking the pancreas, work, and then eventually I'm going to get like a burnout, right? And so it's not ideal for young patients. And then for older patients, to my 80-year-old, I give them this, and what happens? They go hypoglycemic, right? So again, I'm not as worried about that pancreas fatigue in my older patients, but I am really worried about their blood glucose dropping. So again, we've been using it for a while, it's super cheap, but not the best med. Last one, acarbose. So essentially they slow down the digestion of carbs in the small intestine. So it's delaying carbohydrate absorption. And so it'll impact the glucose after meals. I don't prescribe this. It's a tool that you can use, that I'm going to teach you, but it's just not, it doesn't work that well in the A1C. It can cause a lot of GI side effects, and it just doesn't have the bang for the buck. But if you have someone who has all these other contraindications, you can add this to the plate or the menu. And it doesn't cause weight gain or hypoglycemia. So, all right, all these meds, this is a table from that same algorithm. If you're in clinic, it's not on the test, if you're in clinic, and you're like, crap, sulfonylureas, why does Colonel Gator hate them? Oh yeah, they cause hypoglycemia, so you go to sulfonylureas. Oh, increased risk of heart disease. Ooh, that's not good. Causes hypoglycemia. Oh, and moderate to severe hypoglycemia, and it causes weight gain. Oh, I have a patient with fatty liver disease. Okay, so I have fatty liver disease. Neutral, benefit, neutral. Okay, so technically, if I want, I'm going to try to do a GLP-1, SGLT2. So you can use tools like this out there for diabetes management, because it sounds really easy on a test, but it's not in real life. So use these tools. Combos, a lot of these meds are combined. Patients, sometimes they're on a ton of meds, they might like this. All right, so we know we diagnosed a person with type 2 diabetes. They came in with, and they got their wellness labs, and their A1C was over 6.5. Fasting blood glucose was, say, 130, so higher than 126. Physical exam was fine, maybe they're obese. We are deciding maybe we're going to give them metformin, right? First line. You guys feel okay with metformin? Okay. So we're going to give them metformin. So what is my target? So I'm giving them this med. When do I see them back for labs to see my response? When should I see them back? 3 months, because that A1C is right, 8 to 12 weeks. So I'm going to see them back in 3 months. I'm going to give them a shot to do the therapeutic lifestyle stuff and give them a shot for the meds to work. So you see them back in 3 months, and then how do I know if the dose and the med I gave is working? How do I know? A1C, right? So you need to understand your individual, your targets. So these are individualized for the patient. So maybe I'm a 6.5, so you're a 7. I'll talk about the ranges of which, but yeah, you do an A1C in 3 months to determine if the treatment you started, whether it was just lifestyle and medications, did what it was supposed to do. Then from there, do I increase the dose? Do I add another medication? Do I decrease the dose? So again, we use the A1C. We can look at their blood glucose monitor too. But again, it's the A1C. 6.5 to 7 is where we want our adults. So I told you it's individualized. So pregnant patients, I want a really tight control, 6 to 6.5. But everyone else, healthy adults, 6.5 to 7%. If I'm older, why would if I have an 82-year-old, why is my A1C goal 8.5?
Less time.
Yeah, less time. And what am I worried about? Hypoglycemia, yeah, and polypharmacy, right? So I'm less concerned. But a 60-year-old, I'm going to be aggressive, 50, aggressive, 30, aggressive, okay? We want them less than 6.5. And then, so risk assessment on how I determine how aggressive to be is the hypoglycemia risk, polypharmacy, their age, weight, and comorbidities, right? So if I have someone with cardiovascular disease with someone without, I'm going to be aggressive, right? Technically both, but for sure. So that's when they say individualized. Years ago, it was like everybody needs, their cholesterol needs to be this, and their A1C needs to be this. Now it's we have risk calculators, and we have individualized targets. This is just a breakout of hospitalized patients, pregnancy, all of that stuff. It's just it's this little table bigger if you're curious. So this is going to be dived into our lab, but essentially in the lab you're going to be given a patient, you're going to diagnose them with diabetes, you're going to give them medicine, you're going to see them in 3 months, decide is that medicine enough, you need to modify it, and keep going. They're not controlled, When do I start insulin? How do I start insulin? Will you start insulin? Yes, you can, but there's other meds first. And then just all these decision making. So this is I think it's a really great slide. Is it like heavy on test questions? Probably not. But it's just it's great. It's great for diabetes. If you understand, yeah, it's just a good one. Okay. And then again, we're going to go through these tools, talking about when to start insulin, all of this. All right, coming back to this. Why do we care? Why are we not going to let our patient walk around? Oh, but Colonel Heater, I know I'm at 7.6, but I'll do better. No, right? We need to be aggressive. We need to prevent these microvascular changes, correct? All right. How do you treat type 1? Insulin. What do you guys remember about insulin? Yeah, bolus, basal. Yeah, that's pretty much what I know too. No, again, when I was in PA school, I treated type 1 diabetics. Now I don't at all, and I would send that. My adult onset diabetic, I diagnosed him. I started him on basal and bolus, and then I sent him to Endo. But again, most of the time you're going to send your type 1 diabetics to who? Who are you sending your type 1 diabetics to? Endo, yeah. So just don't forget we can use insulin for our type 2 diabetics as well, okay? So type 2, especially if they're uncontrolled. Do I go straight to insulin? If their A1C, just as a guess, if their A1C is 8, should I jump in?
No.
No, we have other meds, but I'll tell you the cutoff of when. We'll talk about that soon. All right, so we have insulin. It's purified human insulin instead of pig insulin. And we have our rapid acting, short acting, and then long acting with the basal. Here, something similar to farm. Do you guys remember these? Yes. These are the exact same tables that they had when I was in school. I swear, they're the exact same. But rapid acting does what? It's short. It reacts, you take it within 5 to 15 minutes, you're going to see a reaction, and it's sub-Q. Okay. Short acting, a little bit longer, 30 to 60 minutes. We don't use this as much. We're going to use this, I use brand names with insulin a lot, and I'm going to try not to do this. So Lizapro, glucide, aspart, we use these rapid acting more than we use the Humulin R or the regular insulin. But this is really important for DKA. So if you have someone with DKA, you can use the regular insulin. NPH is the thing. We don't use it as often, but again, it's basal insulin, and it's over, it peaks in 6 to 7 hours. Okay? And then this, for sure, you will prescribe, and you will need to know. So Lantus or Largine, so basal is all day, right? 24 hours. You're going to give this, and it's like kind of that nice steady state, right? So when does the body, a normal human being, when does their insulin go up? When you eat, right? What happens when I exercise? Do I need more or less insulin?
More. Less.
Probably less, right? Because I'm working out, and so yeah. So so does that make sense why we need type 1s need these boluses for meals and maybe adjust for exercise, and why regardless of that they still need this basal, this long, what is functioning, why is this so useful? Not for food and exercise, what cells need that? Brain, muscles, like, right, yeah. So we need this long insulin, and then we need boluses for when I eat. Okay? Because I like to eat. Alright. Okay. There is, did you guys learn about inhaled insulin? Super cool. I think I might still have samples of it. It works fast. I don't prescribe it that much. Obviously respiratory contraindications, but it's an option, especially because then you don't have to, if you have somebody who's not on an insulin pump, this might be a good thing. You might have patients on this. Here's your summary of all the things. Which ones do I think I care about the most? Your rapid, yeah. Basal, Largine, right? Okay. So, when you have someone who is on type 1 diabetes and they need insulin, or type 2, you can't just give them insulin. You have to give them all the things. The syringes, the needles, the injectors, the pins, all of these things. So there's usually like the auto-correct formulary thing that you can put in, because you will mess it up. I would always mess it up. My disease nurses would just have a paper prescription and give it to the patient. But just so you know, they'll come in and they'll be like, I need more needles. I need more syringes. So be prepared to understand the brand and all of that stuff. So you're not just giving them insulin, you're giving them supplies. See, I wanted to say anything else. Pumps are just so much easier. Pumps are game changers. So people without pumps have a vial and they draw the insulin, they measure it, and they inject it, right? Kids with pumps, the benefit, I think it's coming. I'll tell you the benefit. Sorry, I was trying to just talk. So this is already, you have your rapid acting, which you talked about, the longer acting gets me through the whole day. Or you have the insulin pump that delivers this basal rate through a 24-hour period, but then you can give boluses prior to meals. Okay? So these kids probably have a cell phone now, real early, and it connects to their pump. When I was in the camp, I think I only had I had like a group of, 10 girls, and only maybe 8. 2 of them had pumps. The rest didn't. They're pulling up their insulin. They're giving me injections, not of insulin. I'm just saline. That's how I know the finger pokes hurt so much more. But with the pump, it takes all of that out. But then there's still issues with the pump, right? If it comes disconnected or it malfunctions, there's still risks. Okay. They're all getting continuous glucose monitors, absolutely. Type 1. This is just an example of like how many units they would get. When I had my adult patient, I used my diabetes nurse who worked in internal medicine with type 1s, and together we did this. But rarely you'll have to do this. You won't have to do this on the test. I think, hey, do you guys do that in farm probably? That's a farm thing for you to calculate insulin? Yeah, not for this test, because there's just so much. If we had 3 tests, yes, but no, don't worry about it. It's just an example. Injection sites. Sub-Q. Again, people who don't have pumps, they're going to have lots of calluses on their finger. We'll talk about complications associated with injections too. The final picture. Here's the pens. The pens are really nice. You just set it to, okay, I need 10 units in the morning, just click and turn, and super easy to give. Especially if people have like nervousness about drawing meds up and things like that. These pens did not exist, at least like they do now years ago. But it's really nice. Here's that picture of a pump. Really small, right? Really nice. And does anybody have a pager? No? Anyone old enough to have a pager? My son, like last year, was like, "Give me a pager." Anyway, that's like the size of a pager. Pretty small. When you do inpatient or if you do a fellowship, you'll have a pager. And that's the only time I have them, or when you do rounds, because you're on call all the time. Yeah, I think we talked about all this. So I'm going to get through this and we're going to stop at the Samoji Dawn thing. Okay? So we're just going to finish up the meds. And that's the good stuff. So when do we add insulin to our type 2 diabetics? Switch to red. Okay? So we continue all of their oral medications if they're, except for sulfonylurea. Why? Why do I not like sulfonylureas? 2 reasons. Weight gain and what else? Hypoglycemia. Insulin also causes weight gain and hypoglycemia. You can't take those together. Before I give insulin, I'm going to double check. Have you tried a GLP-1? Are we sure? Does it not work? Is it anyway? So GLP-1s are just a little better than insulin because again, the cardiovascular benefit, weight loss. But we're going to initiate basal insulin. Okay, so the Lantus or the Largine, long acting. And you're going to give it start at 10 units, and then you're going to taper based on their fasting blood glucose. And I'll give you examples of that in the lab. Again, these people are definitely checking their blood glucose regularly throughout the day, or I'm hoping they do. There's a tool out there, so when you're like, I know I need to start Lantus, I'm nervous, there's tools. We'll practice in the lab. Barriers, this is a real thing. Okay, there's true barriers to insulin treatment for type 2 diabetics. Needles, pain, the patients feel like a failure, like, oh no, I tried really hard, but nothing's working, and now I'm stuck, now I have to have insulin. But also providers will let them hang out at like 9% and they exhaust all the other meds, but forget you have insulin too. Okay, so we'll practice with that in the lab so you guys aren't afraid to start insulin. Again, it's better meds, thankfully now, but it's out there. Okay, so that's it for meds. We have 2 complications to end this slide. There's no cases or clean lab until the next block, or so after block part 2. So tomorrow morning we'll start with complications, and then we'll also should be able to finish part 2. So I got you out an hour and 5 minutes.